Hi, everyone. Thank you for tuning in to today's program with Dr. Diana Greene Foster and Dr. Mira Shaw. I'm Andrea Grossman, the founder of Writer's Block, now in our 25th season. I want to thank both Drs. Greene Foster and Shaw for joining us today on the incredibly important subject of abortion. Timing is everything, right? When we set the date a few months ago, I never imagined that today we'd be in the midst of Senate hearings on a replacement for Justice Ginsburg. While the issue of legal access to abortion seems to rear its head frequently, this particular court nomination raises the stakes. Dr. Foster's book, The Turnaway Study, which is so great, examines what happens when abortions are provided or denied to women who seek them. Dr. Foster's study covers 1,000 women over 10 years. Women tell their stories about the impact abortions denied or provided have made on their lives, on their families, on their bodies, on their education and financial situation, on their emotional health, on just about every aspect of life. It's a study told through the prism of these women. So it's not statistics or data that propelled me through this book. It's the personal stories, and sometimes they're so surprising. Dr. Mira Shaw is the chief medical officer for Planned Parenthood Hudson Peconic in upstate New York. She's an abortion provider, and in her new book, You're the Only One I've Told, Dr. Shaw relates the sometimes momentously difficult decisions girls and women have made in seeking abortions. Her book covers a diverse group of women, each story told against the backdrop of unique circumstance. Unique circumstance can be pretty universal, it turns out, and Dr. Shaw's stories are so powerful and so intimate. Please visit our website, writersblockpresents.com, and click on the link to purchase copies of these two really great books. And if you appreciate the programs that Writer's Block hosts, please consider making a tax-deductible contribution to keep these events going. You'll find directions on our website. If you have questions during the program, please email us at reservations@writersblockpresents.com, and we'll try to ask them later. I'm honored to present Dr. Diana Greene Foster and Dr. Mira Shaw.
Thank you so much for having us, Andrea. What a pleasure.
Yeah, thank you so much, Andrea. So I just wanted to briefly introduce myself and then talk a little bit about this book and Diana's book and what impact it has made on me in my career and my work. So as Andrea said, I am the Chief Medical Officer of Planned Parenthood Hudson Peconic in New York. I'm a family medicine physician. I practice full spectrum sexual reproductive health care. I provide prenatal care, abortion care, vasectomies, gender affirming care for the trans community. And I also fly once a month to Indiana to provide abortion care in South Bend with Whole Women's Health Alliance. I must say that I am honored to be here tonight talking with Diana. She and her work have become like the equivalent of a household name in this movement. The Turnaway Study has made a profound impact on the way that I view the work that I do and the way that I talk about abortion with my colleagues and with people outside of this workspace, with friends who aren't in medicine, who aren't in healthcare, who aren't working on social justice issues. It's such an impressive body of work that you have put together over a decade. And it has really, I think, really moved the conversation forward and will continue to do so in the upcoming years. And so I am really excited to be here talking to you because, again, this book is awesome. Your work is awesome. And I just can't wait to dig in and talk to you more about it.
Thank you so much. We can duel promoting each other's books, but I probably like you wrap this book up while the pandemic had started and we're all locked in our own homes and you don't know, you're about to release this book into the world and you don't know what's going to happen. And I got your book in the mail that I should get to blurb your book. And it was like the moment where I knew all was well and I had made it in the world, was that someone sent me this beautiful book. And what is important about it is that it's a window into abortion as it's not normally presented. Normally it's a politically contentious topic and everyone has their opinions, and you don't actually meet in a normal conversation about abortion anyone whose life is actually affected. Is not just the people who have abortions, but also the motivation of the really thoughtful and caring people who provide the care. So I am thrilled to be talking to you and to get the word out about your book as well.
Well, thank you, Diana. You're so sweet. We're both being fangirls of one another. So let's talk a little bit more about that, because you know, again, like I said, your book has become really just an household name. Like I hear the phrase "Turnaway Study" just in casual conversation with colleagues all the time. Can you just describe a little bit about kind of what the process was for putting this project together, and then, you know, what it entailed and how much hard work went into that? I think it would be really important to talk about that first.
Yeah, so the whole study started around 2007, and that was when the Supreme Court was hearing an abortion-related case about one procedure that's rarely done. And the swing vote on it was Justice Kennedy, and he voted to ban the procedure because, as he said, women would come to regret their decisions. And this whole idea that abortion hurts women was so prevalent that this guy, who clearly hadn't talked to very many people who had abortions, thought it was, you know, reasonable to conclude, and he admitted that he didn't have much data to base this assumption, but that women would be hurt by having had an abortion. And so it was really an important time to actually answer the question, does abortion hurt women? And if it does, you know, compared to what? Because you can't compare women who have abortions to women who managed to not become pregnant when they didn't want to and only had wanted children or avoided pregnancy altogether. You have to really look at people who are in the position of having an unwanted pregnancy. What happens if they're able to get that procedure or they're not? And so that's what the study did. We went to 30 abortion facilities across the country. We recruited over 3 years. And every time someone was denied an abortion, we recruited someone. They were denied abortions because they were just over the limit. We'd recruit 2 women just under the limit and 1 woman in the first trimester, and then follow those women for 5 years, calling them every 6 months with this really long interview that was all about their mental health and their physical health and their life aspirations and their relationships and their kids' well-being and their health. And it was a huge collaborative team effort to conduct this study. A group of scientists, over 40 scientists at the University of California, San Francisco, who worked together to make this study happen. And the book is, you know, we published about 50 academic papers in the peer-reviewed science. And clearly you have a unique household that abortion that the Turnaway Study is a word you use a lot in your house, because most people aren't reading the scientific literature, hadn't read our 50 academic papers. And so it was really, this book is an effort to try and share the science in a way that people can understand without having to take statistics courses. And then also to share some of the stories of women who were in the study. So at the very end of interviewing them every 6 months, we picked a random subset and asked them to tell their story in their words. And so in between the chapters are stories of women from the study. And so we have that in common, that we both share the stories of people who have abortions. Tell me what you were thinking when you put your book together.
Yeah, and I want to go back to a few things from your study as well in a little bit, but my book was really, it stemmed from sort of my own personal experience with coming out as an abortion provider and what that experience was like. And I talk about that in the very first vignette in my introduction, about how, you know, I'm the daughter of Indian immigrants. I was born in South Carolina, which is very conservative, and my culture is conservative. Where I grew up was really conservative. And I was concerned for my safety, and I just didn't share much about what I did for a living because it's so highly stigmatized. I was proud of what I did, but I was also terrified. And so it was this like conflict in my head that I had to resolve. And so for some reason, I decided to begin that journey of resolution at a Target when I was home one weekend in South Carolina several years ago. And a woman approached me and asked me, you know, she saw a stethoscope hanging out of my bag and asked me if I was a nurse. And I said, no, I was a physician. And we just engaged in casual conversation, as one does in the South, because people in the South are very friendly and chit chat. And I was chatting with her and she said, you know, what do you do? And for some reason, I just, instead of saying that I was a physician or I was a family medicine doctor, I said that I said that I provided HIV care, trans care, and abortion care. And I was terrified in doing that because I honestly, you know, in my head now, looking back, I feel like I did exaggerate my like emotional response to this woman, but in the moment, that is truly what I felt, was fear. That, and yet instead of a negative response, what I got was a compassionate response. And she also shared with me that she had had an abortion, and in fact, she had had 2 abortions, and that I was the only one she had told. And she never even told her husband. And I was just blown away by this. And I slowly started to come out over the years and become now a national advocate for abortion access. But it wasn't easy in the beginning. It was challenging. It was tricky. But I realized that if I shared my truth, then other people were very willing to share their truth, and that storytelling is really the way to normalize this work and frame abortion as healthcare and a human right, which is what it is, and not how it's been portrayed in the media or in the public eye. And I think that in combination with like your research, which stems from people's stories, it's like the most beautiful combination. I think that it is the way in which we can move forward. And so that was the origin of my book, is this sharing the stories of people who've, you know, confided in me. Someone at a barbecue told me their story. And then a couple years later, I went back and said, you know, I'm writing this book. Would you like to share your story with me? Or, you know, friends connected me, colleagues connected me to people who were really eager to share their story, but didn't really have the platform to do that. And I intentionally portrayed a diverse collection of stories to mirror the types of patients that I see in my health centers. So, you know, it's the young person, the older person, the genderqueer person, the trans person. I see a lot of men who come with their partners and who are beneficiaries of abortion and supportive of abortion. And, you know, really just to normalize it, and instead of siloing it as this procedure, that it's really in the context of an individual's life. And I feel like that's what your work has done really well.
Do you have a sense of which of your stories resonates the most or moves your readers the most?
You know, it's interesting. I think that the one, Sarah is the first story in the book, and it talks about how she experienced intimate partner violence. And a lot of people have shared with me that they experience an unintended pregnancy in the context of intimate partner violence. And so reading that story was really affirming for them.
Yeah.
The one that I think is interesting, and I'd love to hear what you have to say about this, is that I find that a lot of people have mentioned crisis pregnancy centers or fake health centers, and how that is something that they didn't know about, and it's crazy to think that there are more of those centers than there are actual places providing abortion care. And I'd love to hear what you have to say about that in your work.
Yeah. We had a few women who visited crisis pregnancy centers first, mistaking them for clinics. And the one I remember was just livid. She was so angry that she had been, you know, tricked. But I think research that we've done at my university also shows that sometimes those clinics provide, it shows you how little regard we have for pregnancy generally, that can be the only place to get free diapers or, support around, early pregnancy. So there's clearly a need for, they provide other things besides just tricking women. But to the extent that they're there to pretend to be a clinic to dissuade women, it's just not honest, and sometimes makes people really angry.
And
Yeah.
what I've found, and there is some research to show that most people actually so the purpose of them is to trick women and to trick people, but a lot of people actually accessing those health centers go there because of the free diapers and the formula and the resources. So they actually go there.
But that's a service they need,
support.
yeah.
Yeah, rather than the intended purpose of it, which is really interesting.
Yeah.
So, I wanted to ask you about, to highlight, at least for the audience, I think this is so interesting about and we talk about this a lot when formulating our clinic schedules, the number of patients we can see that's feasible to see in a day, depending on the number of providers and the volume and the number of staff we have, and making sure that the workflow, makes sense for the health center. And we talk about how, we never want to turn away somebody who's coming in for an abortion. All the services that we provide are really important. But, abortion is such a special service that we provide, and people come to us oftentimes because we're known to do a really good job with that service. And so can you talk a little bit about what your study found in terms of the harmful effects and what exactly those effects are from turning somebody away who is seeking abortion care?
Yeah. So thanks for asking, because it's so easy to just tell you the idea of the study and none of the findings. But so our study was aiming to look at the mental health consequences, was the primary aim of receiving an abortion. But by having this comparison group of women who are denied an abortion, it's an opportunity to look at, well, what are the harms of restricting access to abortion? And right now, abortion is just, I think for most people, shockingly difficult to access. And it's largely a function of where you live and the laws in your state. So there's been a sharp decrease in abortion providers over time. Many states ban public insurance from covering abortion. Some states even ban private insurance from covering abortion. So the process of, it's like taken out of the normal route of getting health care, and you have to pay out of pocket and find your own information. And many women present too far along in pregnancy to get care. And a few years ago, before many states implemented bans like Colorado's proposed ban at 20 weeks, before that slew of abortion gestation limits, we estimated that 4,000 women every year were denied simply because they were too far along. And many times more than that are likely denied because they could never gather the money they needed, couldn't find a ride there, didn't know where to go. So abortion access is already at this point super tenuous. There's not this idea that we're going to defend Roe v. Wade because what we have under Roe v. Wade right now is somehow sufficient, is overly optimistic viewpoint. So we compared women who received an abortion to those who were denied. And what we found is that on every measure in which they differed, women who were denied were worse off over the long run. So mental health, they were the same. There was no mental health harm from receiving an abortion, nor from carrying a pregnancy to term that you didn't want to carry to term. But in physical health, in socioeconomic well-being, in achievement of life plans, in the chance of having a very high quality romantic relationship, in being able to take care of the kids you already have, and in your chance of having an intended child within the 5-year study period. In all of those areas, women who were denied abortions did worse than women who received it. So it pointed out a whole, that our idea of why women have abortions, that somehow these are frivolous decisions and people are not being careful, Instead, when we asked women, why do you want to have an abortion? Their reasons so clearly predicted the consequences that women experienced when they were denied. And to me, it really says women are making careful decisions. They understand what it would mean to carry a pregnancy to term, and it has lifelong and serious implications on many realms of their lives and of their families' lives. So it was, I think it's a new way of looking at this, that this is not just a one episode of, for someone else to put their moral judgment on a pregnancy or a fetus, but this is a woman deciding about her whole life plan.
Right. I think that you bring up a really important point. And I think that what people don't realize is that, like, yes, Roe v. Wade is currently the law of the land, but for years now, people have been chipping away at access. And so then, there's the argument, well, abortion's legal. Why are we still talking about this? Well, the little rules, laws that have been enacted to create barriers have all of these harmful effects on the lives of people who are trying to access abortion, and turning away because they're being turned away because they can't afford to pay out of pocket. When I work at Indiana, there's a total insurance ban. That patients aren't allowed to use their Medicaid. They're not allowed to use their private insurance. They have to pay out of pocket. So I've literally seen people counting out bills, sometimes not having enough, sometimes having to come back, sometimes having to call an abortion fund for support, sometimes having to work a few extra shifts to make up the difference. And I think that your study really does a good job of highlighting all of the effects of turning people away.
And the downstream consequences of that, if you make people, some very large percentage of Americans just don't have $500 to pay for an abortion, any given month. It's just not many people have that much just stocked away. And the downstream consequences of making people come up with that money is, that they have to tell people about their abortion that they'd rather not tell, that they have to go selling things that they own or begging money from people. It's, it seems like part of the punishing women for needing an abortion is this process to scrounge money to pay for it. Definitely.
And, people think that in some states where patients have to wait 18 hours in Indiana, 24 hours in Texas, 72 hours in Missouri, these arbitrary number of hours to go home and think about their abortion, which is the intended purpose. And when patients don't come back, the antis say, oh, we'll see, they didn't come back anyway. No, it's not because they didn't want to come back. Often, most of the time, it's because they couldn't. Logistically, they had to take off work, have to find childcare, have to get the money. So that's, that's the important point to highlight. What would you say is the most surprising thing that you found from your research that you weren't expecting, that you were, that you learned from, and that wasn't something that was, you were hypothesizing from the get-go?
I don't know if this is a personal knowledge, but I definitely had people who were worried that women seeking abortions, whether they get it or not, lives are kind of this assumption that their lives are chaotic and a mess, and there just may not be a big difference because, there just aren't opportunities to seize. And so kind of worried that the kind of women who have abortions, that it just won't make a difference one way or the other, that they're somehow doomed. And man, were those people wrong. First of all, just wrong on the assumption that people who have abortions or who have pregnancies when they aren't ready for them are somehow, don't have bright futures. They have the same aspirations that we all have of, finding better jobs, moving out on their own, graduating from college or technical school or high school. And so and this one moment of whether they can receive an abortion or not, or whether they're gonna have to continue to be pregnant for many months and deliver a child, that actually makes a huge difference. And we can see in their life course, trajectory, that one moment makes a big difference. The two groups, those who were just over the limit and those just under the limit, were extremely similar before the point at which one group was denied and the other received an abortion, but they diverge in these important ways after. So it's a important moment, and it does make a difference how you treat people, and it does make a difference whether they're able to chart their own course or have their pregnancy dictated by the government or circumstance.
Yeah. I get asked that a lot. Like, what does your typical patient look like? Like, who gets abortions? And I say, it's people like you and me. It's every socioeconomic background, every racial, ethnic minority. People who are young, people who are at the end of their reproductive lifespan. It's really everyone. Religious people who don't identify with any particular religion. I have a story in my book about a rabbi. I have a story about a Muslim woman, a Hindu woman. And so, yeah, it's everyone. And actually, the statistic, as you know, is 1 out of 4 women has an abortion in her lifetime. But there's a lot of people who don't actually touch the medical system enough for us to collect them as a data point. But those people are managing their abortions at home, which we found.
Yeah.
Because unfortunately, many people are being, and self-managed abortion is like a whole nother topic of conversation, but I do feel that, if somebody wants to access the medical system to have an abortion and are not able to, for whatever reason, and they're forced outside of it and have to have a self-managed abortion, when otherwise they would have wanted medical attention. I mean, that's not fair and that's unjust. But they do contribute to the larger percentage of people having abortions.
We at UCSF have been trying to measure the incidence of people procuring their own pills and doing it outside a medical system. And while we're on that topic of how things are changing, you may have been following some of the hearings today for Amy Coney Barrett to join the Supreme Court. And I think a lot of people are worried that abortion rights are, more vulnerable now than they have been, and maybe for years to come. And so can we talk a little bit about what the state of abortion access might become, how much Roe is protecting, or and what the prospects are if an abortion case hits the Supreme Court without extra judges and with Coney Barrett?
Right. Yeah, we can definitely talk about that. I mean, I'm no policy expert. I'm a physician, but I do have to stay in touch with all of this, what's going on in the larger landscape of abortion access, because it does affect the patients that I see day to day.
Yeah.
And Roe is not the ceiling, it's really the floor. And while it's made abortion legal in all 50 states, that doesn't mean it has made it accessible, as you've found from research and as I've found from providing clinical care. And if a case were to make its way up to the Supreme Court and challenge Roe, which has been the precedent, it very well could be overturned. And depending on where you live, your access to abortion care may be protected, or it may go away completely in that state. So, I worry about that. In New York, we just passed the Reproductive Health Acts, the reproductive, the law passed in January of 2019, codifying abortion into the health code. It also permits abortion to occur in the 3rd trimester under various circumstances. It also decriminalizes self-managed abortion, and it also allows advanced practice clinicians to provide procedural abortion. So we made all of these strides in protecting abortion access, in the event that Roe were to be overturned. Whereas in other states, there are trigger laws in place that would automatically make abortion a crime in that state. And so, there are these networks of people in progressive states that are coming together to kind of plan for this, right? Can't predict whether or not it's going to happen, but we really know the harmful effects of not being able to access an abortion, and we know that it is healthcare and it's a human right. So people are figuring out ways to continue access in the event that the worst case scenario. So folks are training more providers. Doctors are increasing the gestational age to which they will provide abortion, increasing the number of health centers, increasing the number of visits in a day for abortion, optimizing workflows to ensure access. Because we don't know. What do you think?
And despite all these efforts, it seems very unlikely, given that people are falling through the cracks now, that it won't be much, much worse. And particularly for low-income people, they won't be able to do the same kind of travel that wealthier women have been able to do to travel to get an abortion. And it seems like a increase in inequity and health disparities, that if abortion is truly illegal in a state, the challenge of getting one will be so much greater.
100%. And, yes, the Reproductive Health Act, which is what I was trying to say earlier, was passed in January 2019 in New York, but that's one of few states who have such great structures in place to protect access, right?
Yeah.
And you're right. It's going to be the wealthier people, primarily white people, who are going to be able to travel to get their health care. Because again, if people are already finding facing hardships to travel 2, 3, 4 hours to get an abortion, could you imagine having to travel states? I mean,
yeah, and people already do travel out of state, but to have to be forced to with no options in state is going to be even harder.
Right.
But I hope that there's the previous Supreme Court case, or 2 Supreme Court cases ago, Whole Women's Health versus Hellerstedt, was in some ways a real, a beautiful decision that said that you have to weigh the evidence. You can't just pass restrictions because you are trying to please some political base, regardless of the impact that those restrictions have, that you have to consider the evidence on how much such a restriction would harm people versus help people, and I mean, especially for these laws that claim that they were going to improve safety. And I was really hoping that we could stick with that decision, because we really do need to weigh the bigger picture of the impact of restricting access to abortion, and not just pay lip service to trying to pass as many restrictions as possible, but to actually consider what would help people get an abortion earlier if that's what they choose. Not make people, not impose burdens that just have no function but to delay or shame people.
Yeah, totally. And I think, and also repealing the Hyde Amendment is a big hope of mine. So Roe v. Wade, legalized abortion in 1973, but a few years later, it was virtually made inaccessible for so many people of color and low-income people.
Yes, people who don't know, the Hyde Amendment is an amendment that gets passed every year that says that Medicaid, the federal health care program, can't use any of its dollars to cover abortion. And so 17 states currently allow state dollars to cover abortion, and the rest, if you're low income, if you're a recent mom who's using Medicaid as your health insurance, it won't cover an abortion if you need one. So, and this actually affects a lot of people, not just low income people, but disabled people and people in the military, people in the Peace Corps, anyone whose insurance federal employees, anyone whose insurance comes through the federal government. So it's actually has a very large impact on making people's lives and decisions more difficult. Yeah.
I'd love to know what you are working on now. What are some of the research topics that you're exploring in this scope?
So right now I am leading with my colleague epidemiologist Corinne Rocca a study of whether the extent to which these state restrictions impair women's access to abortion by comparing neighboring states, people in the process of making the decision to have an abortion, and who's able to get it and who isn't, and how much the state environment affects that. This study was slowed down a little bit by COVID, but we hope to resume full recruitment soon. I'm also running a Turnaway study in Nepal with a scientist there named Mahesh Puri. And we are, Nepal is a really interesting country. It's got one of the best abortion laws. After seeing decades of people dying from unsafe abortion complications, they passed a law to say, okay, we're gonna make it legal because we're losing too many women to these complications. And sure enough, deaths went down from unsafe abortion, and they have, it's just a much better law than we actually have here in the United States in terms of being covered for low income people. And there it's, a very interesting context because child poverty is much higher than it is here. And so in the United States, we looked at the outcomes of the children of women who sought an abortion. So often women say their reason for having an abortion is to take care of the children they already have. And we were able to see in the United States that there were actually differences in their existing children's well-being based on whether their mom received or were denied an abortion. And I expect in Nepal, it may be even greater because more people are living right on the edge of food security. And so not, having a child that you weren't ready to have may show up in, malnutrition for your existing children. So we're looking at both mothers' outcomes, women's outcomes, children's outcomes in Nepal over time.
That's amazing. That is awesome. I can't wait to see that, see the outcomes. And can you talk a little bit more about self-managed abortion and what work you're doing around that?
I am not, my university has many really cool projects to look at what the right, what an evidence-based system of delivering abortion services would be, but I don't claim that as my own area of expertise, so I'd be winging it. But certainly this coronavirus pandemic has resulted in people rapidly making service changes so that people don't have to come into the clinic and be exposed to potential infection from this coronavirus. And so people are learning to streamline access to care in a really interesting way. My colleague Ushma Upadhyay is starting a telehealth study of access to medication abortion. And we've been trying to study how often it happens that people self-manage their abortion.
Yeah, I'm working with her on a project. So yeah, she's done some really good work. My health center, so during COVID, New York got hit pretty hard, pretty fast. And so we had to rapidly modify our protocols to adjust to adapt to the new environment in which we were living in and operating in. So minimizing foot traffic, only allowing patients in the health centers who were needing prenatal care or procedural abortion. Our state permits telemedication abortion, whereas in some states that's outright banned. So we were able to provide medication abortion through telehealth safely, and we know that it's safe through years of research. And so, yeah, because the need for abortion, despite what some conservative politicians say, does not end, and it remains even in the midst of a pandemic, if not more so. I mean, we saw, 30-40% increase in medication abortions during the pandemic, and it's people are at home and having sex and, seeing unintended pregnancies or experiencing intimate partner violence, which we know from research is associated with an increase in unintended pregnancies. So
I actually have a separate study that looked at access to contraception during the shelter-in-place rules and found that 16% of women who were trying not to become pregnant actually had their access to contraception was diminished due to the pandemic and due to the shelter-in-place laws. So it's not just more time to have sex. In fact, we didn't find much difference in the frequency of sex, but we did find a big difference in access to contraception.
yeah. So yeah, people, you know, still need sexual reproductive healthcare services. And so we had to keep our doors open and make ourselves accessible, which wasn't the case. My colleagues in Texas, you know,
Yeah.
one day abortion was banned, the next day abortion, you know, was allowed, and they're having to cancel patients, reschedule patients, cancel patients, reschedule patients because of myths around, you know, abortion procedures needing too much PPE or depleting the supply of PPE that should otherwise be used for more essential services, which is just, you know, not true. And so, you know, the zip code in which you live really determines the healthcare that you receive in this country, unfortunately.
Yeah.
So yeah.
Do we want to try and get to talking about some of the people that inspired us to do this work?
Yes, you go. I was talking last.
I don't know. So first, when Mira and I were planning this, we thought, oh, here are the questions we want to ask, and then they kind of want to ask each other. So we thought we would take turns on some of these. And one question was the people that inspired us to do this work. And I feel I have a sense that the way that we talk about science is that it's somehow like one guy in a lab coat having a eureka moment, and that is scientific discovery. And that is not my experience. My experience is it's a huge group of women scientists in a room and everybody sharing knowledge that other people don't have. So what inspired me was certainly my colleagues. There was about 40 social scientists and clinical scientists, so epidemiologists, sociologists, economists, psychologists, statisticians, nurses, doctors, public health researchers, and everybody. Some people had an experience understanding of domestic violence, and some people of psychological measures of psychological well-being, and together we tackled the statistics of this study. And so I want to dispel the notion that science is a lone person working alone. Okay, that was duplicative, but instead my experience is that it's super interdisciplinary and collaborative, and we would have more women in science if people understood that science is not a science fair where it's a beauty contest on whether your results look prettiest, but it's about caring about the study question and collaborating with people who know things that are different from what you know to create knowledge. So I was inspired by my colleagues is my answer.
Oh, that is so nice. I love that. Well, I can say from the clinical front that that it's very similar, that the work that I do every day is very interdisciplinary. I can't do my job without the help of my nurses and my medical assistants and my administrative staff, and our donors and our activists, my colleagues at organizations like the Physicians for Reproductive Health, who have really helped me become a better advocate for my patients. And they inspire me every single day. My mentor from residency, Dr. Linda Pine, is an incredible abortion provider and activist, and she inspires me every day. And we're learning, I mean, the work that I was doing 5 years ago is very different from what I'm doing now, that it's constantly evolving and we're learning new things. I mean, again, I've been quoting your work and I'm just now for like years now, and I'm just now meeting you. Like, I feel like, you know, your book and your work are just things that are just so second nature to me. And I really do feel connected to you, even though I'm just now meeting you. So you inspire me, and your work has inspired me. And I quote it all the time. I know some of my colleagues are watching because I invited them, because they know that I talk about this a lot. And your work is like truly, truly amazing. And I'm just really proud to even hold this book in my hand. I love it so much.
There's so much, I have so many questions from people, who have questions. So that was duplicative too. So, but more. So, let me see. Sorry about this. Okay. The first question is, what kind of mental health assessment was done to compare women denied versus those who have received abortions? I would have expected denied women would be more depressed.
Mira, I'll let you handle that one. No, just kidding. We use, I might have expected that too. We use several measures of depression, anxiety, somatization, self-esteem, suicidality, in order to make and ask the exact same questions of everybody. And there were no differences in outcomes. In the very short run, women who were denied abortions had higher anxiety and lower self-esteem. But by 6 months to a year, they were similar to women who received abortions. And, you know, I might have expected it too, but except for two things. One is that women are really resilient. And the other is that when we ask women why they want an abortion, rarely did they say, I want an abortion because my mental health isn't good enough to have a baby. They pinpointed all the other consequences, and those other consequences were more salient. It wasn't a mental health story. And maybe we could have selected a group of people who had mental health reasons for abortion, and they may have suffered quite a bit from being denied. But this was a random sample of people not selected by their reason for abortion, and it just isn't the dominant reason, and the other life consequences are much greater.
Great. Do you foresee a sort of underground railroad, this is for both of you, for women seeking abortions whose states have triggered laws if Roe is overturned?
I can contribute to an answer to that. I will say that, I mean, we've already seen a lot of people turning to managing their own abortions, I will say, through medication, through accessing medications online. I mean, with the advent of the internet, when we talk about self-managed abortion, we're not talking about the coat hanger anymore. I mean, information access is just so easy, right? You just Google your question, and if you type self-managed abortion or doing your abortion at home, you'll immediately get a lot of information and access to resources about how to order pills. And there are a lot of organizations doing this work, a lot of reproductive justice organizations, an organization called Plan C. You may have heard of Aid Access. You know, and again, it's from people needing to have an abortion despite, you know, the rules around them and the laws around them saying that they can't. And in terms of procedural abortion, I don't know. I mean, I think that the providers that's trickier. I can't answer that question. I don't know, but I do anticipate an increase in people managing their own abortions, traveling to other states to have abortions, or continuing a pregnancy despite not that being their initial goal.
Diana, what about you?
I think Dr. Mira Shaw has her finger on the pulse more of what will happen. I think it's possible, though, that many people still don't even have internet access, and so Googling that information isn't universal, and maybe there'll be efforts to get the word out.
I mean, do you think Planned Parenthood will be, I mean, what about in these states where, you know, in the South, for example, you know, where it's so difficult to secure an abortion, and, you know, and it's so difficult to travel to a state that will provide one, you know, it's so far, and women have to leave children and jobs and everything. Do you see Planned Parenthood getting buses ready to take people across, you know, to providing states. I mean, that's what I'm envisioning too.
So, you know, well, practicing medicine across state lines is tricky, but it is done in certain circumstances. You know, I will say our Planned Parenthood has mobile health units that we were in the midst of providing medication abortion on, but then COVID hit. But where we're going to go out to counties in New York that have very little abortion access to then set up shop and say, here we are, come get your abortion on the little mobile health unit, the Winnebago. You know, there are a lot of abortion funds and a lot of organizations who do provide travel support and, you know, accommodations, people opening up their homes to provide a roof over, you know, a patient's head. So if they're going to get an abortion procedure the next day, they can stay at a really safe place and get a warm meal before their procedure. You know, I think that people are getting ready to figure out creative and innovative ways to make sure that people have access. There's a lot of people working on this issue, not just providers, not just researchers. There are a lot of grassroots organizations doing this work. So yeah, I mean, I think a lot of it remains to be seen, but I do anticipate new solutions on the horizons for getting people care.
Dr. Foster, please address the issue of women who were unable to access abortion, who had to give birth and give up their child. What were the repercussions and the impact on women's lives?
So in this study, we followed women through more than 4 years after delivering, and very few women chose to place the child for adoption. So wasn't when people are making this, there may be people who become pregnant and instantly know adoption is a decision for them. But in our study, everyone wanted an abortion. And when they didn't get an abortion, they did not automatically choose to place the child for adoption for lots of reasons. But it is true that the people who placed the child for adoption were more likely to experience regret that they hadn't gotten the abortion. That emotionally seems like is not an easy road. Placing a child for adoption is not a simple solution to the problem of unwanted pregnancies. Very few people choose it, and when they choose it, they are more likely to experience regret than if they choose to parent the child. So it's you know, partly their circumstances, their lives may not allow them to raise a child, but it's putting people in a very difficult position. Yeah, we did have a few people also who lost custody of the kid that tried to raise a child and found that they just could not, and you know, had to surrender the child to someone else in their family. And in fact, one woman in particular named Brenda from New York had a life with a lot of substance use and violence, and she also was so super smart, and her take on her experience was that, you know, of understanding the economic, being pregnant when you don't want to be pregnant means you can't just go get a job. So you're totally reliant on your partner, and your partner may be abusive, and the power that he has, because you can't be homeless when you're pregnant and you can't get a job when you're pregnant, can make him abusive if he wasn't abusive before. And she is super, you know, just says it like it is, and says, you know, pregnancy is an incredibly scary thing, especially if you cannot trust the person you're with.
Right. If Roe v. Wade is overturned, how can we ensure the safety of medical providers and patients in states where abortion will remain legal?
That's a great question, and I don't have an answer, except that Mira did a really nice shout out to the Turnaway Study, and I want to take a moment to say how brave she is to come out as an abortion provider, because these are not gentle times where we listen carefully to people, and your compassion and integrity and bravery is really impressive. And you know, I hope you feel supported, and the people that you work with feel like heroes for you know, doing what it's so easy to just take for granted, now, and I hope that we're able to take it for granted in the future, but it's really heroic work.
Yeah.
It is. How do you feel frightened ever? Do you feel threatened or endangered, even though you're in New York?
I mean, I do take precautions. I do, you know, I don't want to jinx myself.
Right.
It is scary disclosing the nature of my work, depending on, you know, where I am, where I'm traveling to. And I talked about that in my book. I mean, let's not forget that many abortion providers have literally been murdered for doing this work. And, you know, I am fortunate to be in a progressive state, to work in a progressive state. I do go to conservative states to provide abortion care periodically. And there you know, I'm not as open, really just for my safety. You know, I am a vocal advocate. I am in the media a lot. I speak out, but I do feel also, though, that it is my moral responsibility to be an advocate for my patients because of the injustices that I've seen on a day-to-day. And so it's a risk that I'm willing to take.
I think last question. Dr. Foster mentions punitive actions against women who have abortions. Allowing or denying abortions can have a huge impact on men. Why has that fact escaped many male legislators? I guess that's for either one of you, but
I love the framing of the question. I mean, apparently a senator just talked about his experience of being a partner of someone who had an abortion. So that just recently happened. But yeah, and we just don't talk about abortion as a personal experience. And so, you know, when we allow people to weigh in on it as a you know, moral, ethical argument that's abstract and doesn't affect real people, folks can take stands that are not ethical because they're not considering the people involved, and they're not, you know, it's a political maneuvering and not a sincerely held belief, is my feeling about it. And the vast majority of Americans want abortion to be legal and think that women should have a right to have an abortion if they have an unwanted pregnancy. So the political posturing is, I don't know why we let it be, but it isn't evidence-based.
Yeah, I mean, the politicians have really used this issue to exploit it for their own political gain and to divide voters. And it's a shame because it's a healthcare issue, it's a human right, and it can, removing access can be so detrimental to people's lives. And it's really an all gender issue. You know, it's, men are impacted by abortion, and you talk about it in your book, I talk about it in my book, and they don't see it that way. And maybe that's something that we need to do a better job of, is just including them in the conversation and really lifting them up as advocates, which I think we could do a better job of as a movement.
well, I think that has to be the topic of your next books. Dr. Mira Shaw and Dr. Greene Foster, I love your books. Everybody go to writersblockpresents.com. You'll see links. These are truly great books, and what a time to read them. It's so important now. I mean, today, next week, next month, it's so important. And I'm so honored to have both of you here at Writer's Block for this issue, which is, you know, the reason it is how many of us vote. And so thank you. And I look forward to seeing more from both of you, and, you know, carry on, and everybody read these books, because and it's 21 days away from Election Day, so
Yeah.
it's important.
Yeah. Well, thank you so much for having us.
Thank you so much, Andrea, and thank you so much, Mira.
Yeah, no, thank y'all
for coming
to talk about this. So thank you so much for giving us the opportunity.
Thank you, and we'll talk to you soon.
Okay.
Bye-bye.
Bye-bye.